Okay, so as I just said, we're hosting today's webinar on trends and developments in HIV testing. We're joined by two excellent speakers today. So we have Dr Alison Brown, who is Interim Head of HIV Surveillance, and she's going to be talking about the latest HIV testing data and what we've learned from the 2021 data. Then we will be hearing from Steve Hindle, who is Project Manager for Opt-out HIV testing at NHS England, and he will be giving us an update on the Emergency Department bloodborne virus opt-out testing programme. If you have any questions throughout the presentation, please do use the Q&A function. We'll have 10 minutes at the end of each presentation to do a bit of Q&A, so please do pop your questions in there as we go. And at the end of the session, I will be just popping a short SurveyMonkey link in just to be able to evaluate the webinar. So please do take time to just click that link before you disappear at the end. Okay, thank you very much for joining us today, and I'll hand over to Dr. Alison Brown.
Thank you very much, Nicola. Can you see my screen?
Yes.
Thank you very much. So my name is Alison Brown and I work for the UK Health Security Agency in the HIV and AIDS reporting section. So what I'm going to do today is provide an outline of the latest HIV testing data collected by the UK Health Security Agency and show how HIV testing is pivotal not only in saving lives, but also in driving HIV prevention. So England is one of the few countries internationally to have met the UNAIDS 95-95-95 targets, whereby the target is that 95% of people who are with HIV are diagnosed, 95% of people who are diagnosed are treated, and 95% of those who are treated are virally suppressed. And obviously, if you are virally suppressed, you have undetectable levels of virus and cannot pass HIV on. So in England, we have 95% of people who are diagnosed, 99% of people of those diagnosed are on treatment, and 98% of those who are on treatment are virally suppressed. So that's testament to the NHS. We have such fantastic levels of HIV treatment and care that such a high proportion of people living with HIV are treated in care and suppressed. And it's partly because of the success that an ambition has been launched by the DHSC to reduce HIV transmission by 80% between 2019 and 2025. The overall aims are to reduce HIV transmission by 80% and AIDS and HIV-related and preventable deaths by 50%. This graph here shows new HIV diagnoses first made in England over the past 10 years or so. And at the bottom, it shows the number of AIDS and HIV-related preventable deaths. The baseline is shown in red. Obviously, new diagnoses aren't a good indicator of HIV incidence on their own. They need HIV testing data behind them because HIV is an infection with a long incubation period, and you can live with HIV for many years. But we're using HIV diagnoses first made in England as a proxy because if we modelled estimates of undiagnosed infection, those estimates would get increasingly uncertain as we reduce numbers further. We take diagnoses first made in England because these reflect infections most likely to have been acquired in England. And just for context, of all diagnoses made in England each year, 75% were first diagnosed in England, with the remaining 25% of people diagnosed previously abroad who've since arrived in the UK. If we are to meet these targets, we need to reach these little triangle markers here. And what we see is a steep decline between 2019 and 2020, in part due to reduced testing during COVID era, and then a plateauing in 2020 and 2021. But the declines in HIV diagnoses aren't equal between groups. In the left-hand side graph here, you can see first diagnosis first made in England by exposure group, and we've seen a particularly steep diagnosis between the decrease in diagnoses between 2019 and 2020, partly due to COVID, and then a slight decrease again by sexual men between 2020 and 2021. On the right-hand side, we have a CD4 back calculation model, which looks at the distribution of CD4 counts, which shows an indication of how well your immune system is functioning, and uses that to estimate how long you've been living with HIV. And these estimates confirm that we have a continued decrease in HIV incidence in gay and bisexual men, which is good news. However, amongst heterosexual men and women, we've seen a much shallower rate of decline in new diagnoses and a slight uptick in 2020 and 2021. And when I talk through the HIV testing data later, we'll look in terms of what the implications of that are. So we've adapted this model from CDC, and this just shows how pivotal HIV testing is in response to HIV, both in terms of saving lives, also in terms of HIV prevention. And it shows very nicely how HIV testing is pivotal, not only if you have a positive test, but if you have a negative test. So if you enter the model at the top, you have an HIV test. If you're HIV negative, that provides access to PrEP if that would benefit you, and also information about how to reduce risk of HIV transmission. Again, you may, if you are on this left-hand side of it, then go on to acquire HIV, or you may have another test and test positive, in which case it's really good in terms, the route there is in terms of making sure you have rapid access to treatment and care, both to make sure that if you're living with HIV, you have a long and healthy life, but also to attain an undetectable viral load, which will make sure that you cannot pass HIV to sexual partners, even without PrEP or condoms. And you see here, it's not only important just to have an HIV test, but that link to care and that engagement to care is absolutely vital in making sure that we are keeping people healthy and reducing transmission. But you see that HIV testing is the way in to the prevention model there, so it's absolutely key to the work that we do. So the primary aim and the primary purpose of HIV testing is to prevent death. And unfortunately, we still have a much higher rate of 1-year mortality in people who have been diagnosed late compared to people who've been diagnosed promptly. Overall, we get about 500 to 600 deaths a year, and we estimate about 40% of these deaths are preventable and HIV related, and they're predominantly in people who have been diagnosed late. These are people with a CD4 count under 350, and that indicates they've been living with HIV for at least 3 to 5 years. This graph here shows that we have about where it used to be 10-fold risk. It's much higher due to impacts of COVID that we're trying to delineate. Much higher risk of death if you're diagnosed late compared to if you're diagnosed promptly. And that risk of 1-year mortality from diagnosis increases very clearly with age on the left-hand side, and also amongst heterosexual men in particular compared to heterosexual women and gay and bisexual men. So that's the first reason we test for HIV, to prevent death and morbidity. So who are the people who are most vulnerable to being diagnosed late? People who are diagnosed late. So this graph here is quite busy. In the bars and on the left-hand axis, it shows the numbers who are diagnosed late each year. And in the triangles and circles and squares, you can see the proportion who are diagnosed late. So if we look first at the bar on the far right, the total, you can see in 2021, approximately 43% of people who are diagnosed with HIV were diagnosed at a late stage of HIV infection, which means they've been living with HIV for about 3 to 5 years and potentially passing on HIV if not on PrEP or not using condoms. COVID has had a big impact on HIV testing patterns, and you can see that as a consequence of this, the number of people who are diagnosed late has seen a slight uptick up from an overall decreasing trend over the last few years, as people who weren't tested during 2020 are now coming forward at perhaps a slightly later stage in 2021. We'll continue to monitor that, and we'll keep looking at the deaths as well. But this shows we do have a backlog of individuals who have not had an HIV test who benefit from doing so. Again, you see the people who are, you can see the proportion who are diagnosed late increases with age. People who are older, more likely to be diagnosed late. We see a higher proportion diagnosed late amongst people of Black African and Black Caribbean ethnicities. And we also see a higher proportion of people diagnosed late amongst heterosexual men and women and in areas outside of London. So how many people do we need to test to find everybody who is undiagnosed? And that's a complex picture because it's by definition, you don't know how many people who are undiagnosed. We use a model with our colleagues at the Medical Research Council using a multi-parameter evidence synthesis model, which combines information about people living with diagnosed HIV and the rate of positivity of testing in sexual health clinics to estimate undiagnosed HIV infection. And in 2021, we estimated that 4,400 people are undiagnosed, but the credible intervals, which is the certainty that the actual figure lies within the range, is 95%, varied from about 2,000 to 6,000. So we think it's likely the undiagnosed number is anywhere between 2,000 and 6,000. What you can see here.
Sorry to interrupt. We've just had a comment. Somebody's struggling to see the slides a little bit, and could we make the slides?
Oh, I haven't put them on. Oh, I'm so sorry.
Oh, that's okay.
Is that better?
Yes.
Okay. I'm really sorry about that. Okay. So the distribution of undiagnosed HIV infection is not equal. You can see that most undiagnosed HIV infection is in areas outside of London. We have twice as many people live with undiagnosed infection outside of London compared to in London. If you look at gay and bisexual men, who are the teal without being shaded or spotted, inside London, you can see there has been a reduction in undiagnosed HIV infection and a slight reduction for Black Africans and non-Black African populations in London also, but not as steep. In areas outside of London, in the rest of England, you can see that there wasn't a decrease in undiagnosed infection between 2020 and 2021, and the numbers of people living with undiagnosed infection in outside of London in England have remained stable between 2019 and 2021. You do notice, obviously, that these credible intervals are extremely wide, so there's lots of uncertainty as you break down these numbers further. And it's particularly challenging that these numbers become small because it's very, very difficult to be able to test many, many more people now to find a positive compared to a few years ago, which makes it more challenging in terms of pushing the case forward in terms of the cost benefit. Okay, I'm having difficulty making my slides move on now. Okay, there we go. So I'm now going to go through the different data sets we have showing the different strategies of HIV testing. I'm going to start off with partner notification in sexual health clinics, and this is by far and away the testing strategy that's associated with the highest level of positivity. So these are people who are coming in for a test because they have been notified that they have had a sexual partner who has been recently diagnosed with HIV. And what this graph shows is the number of people who have come into a clinic because the partner has tested positive. And then this, the green spotted section shows the partner has come in for an HIV test but has not been tested. And then the stripe shows they're tested negative. In contrast, on the right-hand axis, we show the new diagnosis to partner notification ratio. So then what this means is from every diagnosis we have, what's the ratio of that diagnosis to new diagnosis found to partner notification? And you can see that this is relatively, it's still under warm, shows we have a lot more work to do, but more of concern is the fact that partner notification, which is associated with a positivity rate of about 1%, it has really dropped off due to COVID, particularly in gay and bisexual men. So we really need to make efforts now in scaling that back up. This graph again is very busy, but it shows the number of people who have an HIV test in sexual health clinics by sexual orientation. So we take the left-hand segment first, and you can see in the columns is the number of gay and bisexual men who had an HIV test. And in the stripe part, it shows of the people having an HIV test, how many people had an HIV test that was through internet services. And the first observation to make is the proportion who are testing via internet services has increased dramatically, accelerated by COVID. So this is now the most common way that people are having an HIV test in England. You can see between 2019 and 2020 for gay and bisexual men, there's a small dip in the numbers having an HIV test, but the numbers have since recovered in 2020 and 2021 to pre-COVID levels, which is reassuring. The positivity of the test is given in orange dots on the, and refer to the second y-axis, and you can see these numbers have declined over time as well. So it's this, together with the modelled estimates of CD4 back calculation, the high sustained numbers of testing combined with the numbers of new diagnosed infections, show to us that transmission is decreasing in this group. And the top part refers to London, and the second part relates to outside London. However, you can see there's a very different picture in the right-hand side, which relates to heterosexual women and men. Women are the first set of columns, and men are the second set. And you can see here there's a much steeper fall in numbers having an HIV test between 2019 and 2020 due to COVID. And more importantly, that fall in numbers testing has not recovered in heterosexuals. So this information, combined with the uptick in new HIV diagnoses in this population, suggests to us that HIV transmission is continuing in this group, and we need to do much more work in encouraging heterosexual men and women to have an HIV test. We also have a look through GumCAD data of the proportion of the proportion of people who attend the clinic who are eligible for an HIV test, what proportion are tested, not offered, or declined. So overall, of the people who are eligible for an HIV test, about 45% of people are tested. Overall, about 20 to 30% are not offered a test, and at the top there you can see there's about 20% who decline the test. And you can see that there's a big difference here between groups. In particular, amongst women, particularly Black African women and non-Black African women, a much higher proportion of people are not offered a test and not and also declining a test, and that's a particular concern. We've tried, we worked really hard with the service providers to make sure we're stripping out people who are not eligible, for instance, people who are attending purely for contraception. But this is something we're looking into as part of the action plan. We're looking at reasons why people might not be offered a test and might decline a test. And then finally, it's hard to see, but there are yellow dots related to the second y-axis, and you can see here the much higher positivity for gay and bisexual men, and for Black African heterosexual women and Black African heterosexual men, compared to very much lower proportions that are testing positive for non-Black Africans on the right-hand side. Okay, and then we also have a look at the frequency of HIV testing in gay and bisexual men. National guidelines suggest if you are a gay and bisexual man, you should test at least once a year. But if you're having sex with new or casual partners, you should be testing every 3 months. And here we have a look of people who had an HIV test, the proportion of people who had a test at least once the previous year. And you can see here that about 40% to 50% of people testing in 2021 also had a test the previous year. Within the same clinic, we also have a look at the proportion of gay men who had an HIV test who had 4 or more tests the previous year. And you can see that this has declined slightly, but it's reduced, but it's varying between about 2 and 4%, so potentially more work to do there. I've also tried to summarise information we know about HIV testing in other settings. In the financial year 2020 to 2021, we know that of antenatal clinic attendees who are eligible for antenatal HIV screening, 99.8% of people had a test, and the positivity remained extremely low at 0.96 per 1,000 eligible pregnant women. And this uptake of antenatal testing meets the UNAIDS threshold. We also work with OHID and the local authorities for self-sampling kits. So in 2021, we had 38,000 tests rolled out or undertaken with a positivity of 0.7%. The survey of HIV testing in community settings, we had about 11,000 tests, which led to a positivity of 0.4%. We also collected information from the blood donation scheme, where 1.7 people donated blood and were screened for HIV, and the positivity was extremely low at 0.5 per 100,000 tests, Obviously, there's a huge bias here because it's a self-selecting population. And then of people who are diagnosed with TB, 97% of people agree to have an HIV test but don't have the positivity. We do also have the Sentinel Surveillance Laboratory of bloodborne viruses, which is not fully representative of the entire UK, but represents 20 major labs. And here we see we did about over 100,000 HIV tests in ED settings, 94,000 tests in GP settings, and in HIV outpatient care, 221,000 HIV tests. And here you can see the positivity rate of 0.6% for ED, 0.2% for GP, and 0.4% for outpatient care. And you can see that by far the highest prevalence rate there is for ED testing, and Steve Hindle is going to talk in much more detail about the 2022 rollout of the opt-out ED testing, so I'm not going to focus on that. HIV testing is, of course, absolutely pivotal in our response to HIV, but we also need to put it into context. So this graph here is a little bit complicated. So we just focus on the top part of the graph. This shows the estimated number of people who are living with transmissible levels of virus who could potentially pass HIV infection on. So in the darkest blue, we have the number who are estimated to be undiagnosed, which is 4,400. And then we have an additional 140 people who are diagnosed but not linked to care. We have about the same number of people who are diagnosed as people who are not retained in care for at least 15 months. Then we have just over 1,000 people who are in care but not on treatment. And then we have about 1,800 people who are on treatment but not virally suppressed. And what this graph shows is, yes, HIV testing is important, but of everybody who has potential to pass HIV on, it only makes up about 30% of all people with transmissible levels of virus. So we also need to make sure that we invest in making sure that people are retained in care and linked into care. And that's particularly important as we're expanding HIV testing into other services. We need to make sure that those routes of transfer are absolutely concrete. So again, we measure this. We've measured the proportion of people who are linked to care within 2, 4, and 12 weeks. So in 2021, 79% of people who are newly diagnosed were linked to care within 2 weeks, 90% within 4 weeks, and 97% within 12 weeks, which is particularly reassuring, because again, we need to work hard about those individuals who do not make it into care. And we also estimate the number of people who have not been seen in care for at least 15 months. And in the pre-COVID era, we had about 2,500 people who were lost to care each year. We are able, through our information systems, to see if people are linked to care at different sites in the UK, so we can make sure that they are being seen elsewhere. But we routinely send lists to clinics of people who have not been seen for care for at least 15 months and not been seen for care in other services, so sexual health advisors can use that information to call up patients and try and encourage people to come back into care. Unfortunately, due to COVID, that number essentially doubled in 2020, and we had a much higher number of people who have not been seen for care, which is particularly worrying. This is also driven by a change in practices due to COVID. We're seeing more virtual consultations for HIV, and more people are seen for care once a year compared to about 3 to 4 times a year. In 2021, again, the numbers have come down a little bit, but are still too high. So this is something we're continuing to prioritise, not only to try and make sure people stay healthy, but also in our ambitions to end HIV transmission. So in terms of our limitations, we need to make some improvements to how we monitor HIV testing outside of sexual health services. Whilst we have exceptionally good data of people attending sexual health clinics, our data on in other areas outside of sexual health clinics is patchy and not necessarily representative. We need to make sure that we can monitor those tests and have people linked to care afterwards. Finally, and also in sexual health services, where we have a HIV test, we're unable to deduplicate between sites. So we're not able to see if people look at patterns of testing where people change between sites, unfortunately. So in conclusion, HIV testing is absolutely essential, both in terms of saving lives and preventing onward transmission, and that's regardless of the test result. A negative test provides access to PrEP, and a positive test provides very quick access to care and treatment, which not only saves your life, but also means you have the opportunity to become thoroughly undetectable and not pass on HIV. HIV testing activity has been severely impacted by COVID-19 with an unequal recovery. For gay and bisexual men, we are now confident that the number of people having a test is meeting numbers previously observed before COVID, but this is not the case with heterosexual men and women. And it's really important that we need to address that and try and get those numbers back through the door or internet testing. Internet testing is now the most frequent way to test, which is fantastic. The more ways we have to test, the better. But we do need to make sure that that the promotion, well, not the promotion, but we need to make sure that there are options for people for whom internet testing is not accessible or preferable, to make sure we still have places for people to test who prefer a face-to-face visit. Steve Hindle is about to talk about the fantastic success of the opt-out ED testing. That undoubtedly is producing a huge amount of positives, which is fantastic news. But we do need to have a look at this in terms of evaluation of making sure that people who are tested in this way are quickly linked to care, and people who are not disadvantaged are being tested in ED settings compared to sexual health settings. And also, equally important, we need to make sure that these are new diagnoses and the proportion which are people who've been previously diagnosed. If we're picking up people who are previously diagnosed, this is also a good result, because it means we are successfully potentially linking them back into care as well. And then finally, HIV testing is vital, but it is not something that can be done in isolation, and it must always be accompanied by concordant efforts to link to care and retain in care as well. Thank you very much.
Thank you very much for that, Alison. That was really interesting. We've got 3 questions in the chat. So if we just go through those 3, in the interest of time, if any more come in, if we do them at the end, just to make sure that Steve has time to go through his presentation. So the first question is from Lauren, and she says, how confident are you that the late diagnoses of exposure from heterosexual contact for men is actually within heterosexual men, as opposed to heterosexual identifying MSM who aren't necessarily open about the fact that they're having sex with men?
That's a great question, and we can really only go by the information that that individual imparts to their healthcare provider. As far as sexual health clinics, as far as is possible, are all trained in being inclusive as possible to LGBT communities. Obviously, there may be a subset of people who are anxious about revealing their sexual orientation. We do have a very small minority of people for whom information is updated, where their heterosexual record is updated as being updated from being heterosexual man to gay and bisexual men after that person disclosed what they feel more comfortable in their care. But those numbers are very, very small, and we do ask people to validate it. But we can't rule it out entirely, but we have to go with what the individual says.
Okay, thank you. And there's a question from Joe who says, could you talk a little bit more about the need to get heterosexual people to test? For example, when an outreach worker encounters heterosexual people, is there anything that they could say to them that would encourage them to test, such as, I heard there's more new transmissions among heterosexuals at the moment. Is there any advice around that?
I don't think we could say, I think we need to get our messaging right. I mean, THT and NAT have both shown that there's still not good enough awareness about U equals U. So I think there is more work everyone needs to do in terms of getting the message out there that HIV has changed. It's not a life-threatening, whereas it is it's not a fatal infection, but it is something that is treatable, long, healthy life. And also the news that U equals U really revolutionizes the confidence with which people could have sexual partners and relationships, etc. So trying to get the message that HIV change, I think, is really helpful. From a practical point of view, from our side, it is extremely difficult because obviously there are very, very, very many more heterosexuals around than there are gay and bisexual men, which means you have to test huge numbers more to get one positive. And I think that's where the challenge is. We're looking into what can be done in lower prevalence areas to see what the characteristics are of heterosexuals who are diagnosed there. I think it's a combination of getting that messaging out, and then initiatives such as the opt-out ED testing that can hopefully pick up the heterosexuals as well. But there's something not going quite right in terms of the numbers testing in sexual health clinics in the post-COVID era compared to pre-COVID era, and we need to try and resolve that.
Okay, thank you. And there's a question from Daniela who says, there's a few more questions, but I think we'll leave those to the end just in the interest of time. So I'll just do this one from Daniela. What is the rationale for people accessing contraception being ineligible for a HIV test? Because those people are also sexually active and theoretically could acquire HIV.
Okay, and then there is a clinical discussion and a pre-assessment that is done. So obviously you might be attending for contraceptive reproductive health purposes and you are sexually active, which means you'll be eligible. But there are also some youth clinics that would run for people who have not yet had sex, who want to talk about different forms of contraception, etc. Obviously, for people who are not yet sexually active, it wouldn't be appropriate to have an HIV test. So it goes by the algorithms of risk. So I would imagine if you have had at least one sexual partner and not used condoms, then you potentially be eligible to have an HIV test. But there are a lot of people who attend these services. A lot of these are split services purely for contraception, including young people, clinics who might not yet be sexually active and for whom it wouldn't be appropriate to offer an HIV test.
Okay, yeah, that makes sense. Thank you very much. I think we'll return to the questions at the end just to make sure that we have time to also talk about ED opt-out testing. So I'll hand over to Steve. Thank you very much.
Good morning, everybody. My name's Steve Hindle, and I use pronouns he and him. I'm just trying to share my screen so that we can move forward. Here we are. And I'm having some problems getting this to share. I'm sorry, Nicola, would you mind sharing my slides for me unless I can bring this up? This worked perfectly well in rehearsal.
I think you might have shared your screen rather than the slides, because I can see myself.
Indeed, and I'm trying to share the screen. There we are. Thank you so much for the patience.
No problem.
So let's put ourselves onto slideshow. Okay, that's not happening. So this is going very, very slowly. So let's think about emergency department testing. So we know that emergency department testing has been happening something more than 10 years in various places, but it's never really managed to get to the scale as we are now doing. So there are various things around that. The first was the Elton John AIDS Foundation Social Impact Bond that worked with South East London providers around emergency department, primary care and community care testing. And that created a lot of evidence that was influential. But there was also the APPG on HIV and AIDS that had looked at emergency department testing amongst other forms of case finding. Beaver and Bash had called for emergency department HIV testing in areas of very high or high. Fast Track Cities, which is a global organization where cities sign up in order to achieve zero HIV transmissions, had also produced a report with very wide stakeholder consultation. The HIV Commission had recommended it. Our colleagues at UK HSA had been able to show the prevalence of testing, and all of these things came together to create this action plan towards ending HIV transmission, which was launched in December of 2021. And let me just see if I can move on. I'm sorry for the I'm having the same problem as Alison, that we're getting a very slow ability to move on slides.
It seems to be.
It worked for me, Steve, if I scrolled rather than clicked. I don't know why.
I'm not getting that ability to do so. I think, Nicola, if you can help me on this.
Yeah, I can.
Apologise to those who are waiting for us. Let's just stop sharing. So here we are. Thank you so much. And I should acknowledge my colleague, Dr. Rachel Hill-Toot, who's clinical lead, who's not able to be with us, but has provided much leadership. Okay, next slide, please.
Okay, and the one.
So what happened in London was that Ian Jackson, who's the commissioning director for specialist commissioning, had conversations with colleagues in NHS England hepatitis C programme, and came to the conclusion that if we were taking a sample for HIV, what else could we do with that sample? And it became clear that we could also test for hepatitis B and hepatitis C. So NHS England HCV elimination programme came on, and we are now testing in most places for bloodborne viruses of HIV, HBV and HCV. Next slide, please.
I think it's also moving a bit slow.
Okay. So, dynamic commissioning was a phrase that Ian Jackson came up with, and it basically means about learning from the approach in COVID to try something and effectively to do kind of PDSA type circles, so that if it didn't work completely, then we just adjust it. And you can see here that there are three main aims. It's to increase implementation and uptake. It's to ensure the prompt access that Alison has highlighted is crucial, but also to increase community and peer support offer. Now, we know that community and peer support is a really good way to retain people in care who might otherwise have disappeared. And it's also a good way to give people the support that they need to enjoy the highest quality of life. Next slide, please. So where we are at this moment in time, we have 34 emergency departments, of which 33 are testing for HIV, 21 additionally testing for HBV and 23 for HCV. These emergency departments are largely in the very high areas of diagnosed HIV prevalence. What happened in London was that London included all trusts within London, so there were actually a few trusts who were in the areas of high diagnosed prevalence, but most of the others, and they were in London, in Blackpool, in Manchester, and in Brighton. And as previously said, some trusts have been testing for a number of years, and they generously shared their learning. ICSs have been offering leadership, and the community organisations are active partners sharing their experience of providing support. And Fast Track City has been very helpful within London in terms of giving an overall framework for community organisations. Next slide. So I mentioned a little bit earlier about Fast Track Cities and the report that they produced called Evolving HIV Care. And this was a wide sector production of clinicians, of people living with HIV, of community organisations. And using that, we created a charter or rather the HIV and hepatitis communities developed a community chart, and you can see here some of the important things on it about community culturally appropriate support, about transparency, about understanding who's providing what across London, the long-term cost benefits of financing community organisations to support engagement in care, and an openness to form strategies for engagement. So although this was done in London, the principles are sound for other parts of the country. Next slide, please. So this is perhaps one of the more interesting slides. So what have we actually done? We are still waiting for some reporting from November, or rather for December. So we have April to November and then some gaps in December reporting. But broadly speaking, you can see that about 2 million people have attended emergency departments, of whom about 1.1 million have had bloods drawn as part of their usual ED visit. Now, those are the people that we're concentrating on because we're only offering tests to those people who are having bloods drawn as part of their routine ED visit. Of that, some 650,000 HIV tests, surface antigen for HPV of about 200,000, and HCV antibody tests. An HCV antibody test merely says whether you've ever had HCV. It doesn't say whether it's active. And so we then go on to take an RNA test to say whether it's active or not. What we can see here are these numbers of how many new diagnoses and the previous diagnosis but not in care, a number of different ways that that group is sometimes described. It might be called lost to follow-up or disengaged. And you can also see how many people are in care already. And for hepatitis C only, we can see those who previously cleared the infection are now reinfected. And if we were to add up those first two columns and the 11 hepatitis C that have been reinfected, you can see that we've reached about 1,500 people over the course of these 9 months. And they potentially have the chance to engage into care, either for the first time or to re-engage. Certainly every effort will be made to do that. So that'll be 1,500 people. Worth saying, just to be completely clear, that these are the results that have been reported by the sites, and it's subject to UK HSA validation. And when we say new diagnosis, we talk about that as being new to that particular clinic and the patient not disclosing they're under care elsewhere to their clinician. Next slide, please. I'll let you read these. I think for me, it is what people say is probably the most important thing about any of these kind of healthcare interventions. So you can see in the first of somebody who didn't know that they had HIV, was diagnosed and was very pleased and believes that ED testing should be rolled out everywhere. The second speaks to this issue about assumed consent. So if we were to walk into an emergency department that was taking part in this ED testing, we would see posters on the wall, we'd see posters in the consultation rooms, and we would see posters in different languages saying that we will be testing because this is an area of very high HIV incidence. We'll be testing. Those posters have now developed to include hepatitis B and hepatitis C testing, where that hospital is taking part in that testing. And we're working on an opt-out basis so that it will be done unless somebody tells us not to. The issue of assumed consent is around, is there a conversation between the clinician and the patient, or is there not? And we're working on the basis of assumed consent that it is sufficiently in the public health interest for people to be tested that we believe having the posters in different languages is sufficient. And you can see, so here's somebody who said, I didn't see the posters, I wasn't going to give consent, but actually because I was tested and I was found to be positive, I'm really glad, because now I can look after myself and look after my loved ones. Next slide. So some people on this webinar may have seen the 100 Days report. So this was published in December. It got very good coverage. It was very good at raising this issue. Raising this issue is really important because HIV still retains stigma, both amongst the wider population and sadly also amongst some of the NHS staff group. So getting this out, getting people to understand the benefits of getting somebody tested and then linked to care so that they have a better health and well-being outcome, but also there is a reduction in transmissions, and also it's cost effective because if we can find people early, then they're not less likely to transmit HIV to somebody else, or Hep C, Hep B, but also they're less likely to have extensive inpatient stays. Next slide, please. So we've been sharing this wherever we can. So there was a good practice guidance that was created at the very beginning of this project, which acts to inform local organisations creating their own SOPs. We had a big learn and share event in September, 140 people, and that was found to be very helpful. And we talked about what's worked well, what hasn't worked well, and how people can further develop their own practice and offer resource to others. And you can see in these bottom that there's actually quite a lot of interest. England is leading the world in this. It is something that we can be very proud of, that the HIV services that are already world class. And this is another part where we are actually leading the world in terms of ED testing. Next slide, please. So what do we think has caused this? Well, it's very largely based around the HIV, hepatitis and ED clinicians who have just been passionate about this. They've built on existing testing experience, and they've built on the existing high quality guidance available from NICE and from BEVA, BASH and BIA. The Pan-London approach has been really helpful for those organisations in London. There's also been a Pan-Manchester approach being taken by Greater Manchester ICB, which again has worked very well for those organisations testing. The partnership with the Hep C elimination programme team has been fantastic. And it's worth saying that for ED staff who are under extraordinary pressure, the feedback that people have been found is very helpful. It's very helpful for them to lift their morale and also to focus on testing to as high a percentage as they can do for people coming through. And obviously, if you're testing for HIV, Hep B and Hep C at the same time, you will find more people simply because you're doing 3 sets of tests. So being able to feed that back to the ED team is really helpful in showing the importance of it. We've worked with a very vibrant community sector, and that's within the framework of Fast Track City. And we've had a strong focus on sharing learning challenges and success, as in this kind of meeting. And finally, I'm grateful to my London Business Intelligence team who have been allocating resource to help provide a national picture of this. Next slide, please. We talk about community peer support, and I think it's worth showing that there is partnership across different organisations in providing this. So this was won by Metro, Positively UK and Terence Higgins Trust. And it's a really important part of both offering support, but also improving the chances of somebody being retained in care. And next slide, please. This is the final slide. So we're looking to implement opt-out testing in the remaining trusts where they're just doing HIV, and also ensuring appropriate referral pathways. We want to increase the uptake of testing to 95% if possible, and also increase the number of sites blocking those who've already HIV tested previously. So in other words, if you've had a test last week, you don't need another test today through an emergency department, and will be either at 3 months, 6 months or 12 months according to what the local hospital clinicians feel. We want culturally appropriate community support. We are this week rolling out a new data collection format. Our colleagues at UK HSA, led by Alison and Monica Desai, are developing a 12-month evaluation report. Important to realise that we are collecting activity, we are not collecting demographic data, so it's really important for our close partnership with UK HSA, for Alison and Monica and their teams, to be able to tell us more about the numbers and who those people actually are. Beaver are developing a rapid guidance statement on assumed consent to inform their membership, and there's another learn and share event being planned for 3 months' time. Okay, so that's me finished. Very happy to take any questions.
Great, thank you very much for that, Steve. I know a few questions have been popping in, so sorry, so we've got a question here. So a few people are asking, can we have copies of the slides? So if you're willing to share your slides.
Sure.
There we go. Somebody has asked, Rutendo has asked, what are the cost implications of testing for BBVs? If not significant, could this be expanded?
So there is a very lively conversation going on at the moment about whether it is possible to have another phase of expansion. At this moment in time, it rests with people more senior than myself, the ministers and NHSC and DHSC. Obviously, there would be some benefits because we would be able to reach more people, but it's also a cost at a time when the NHS is very financially stretched. So I am waiting to see the results of those conversations, and should we expand, then we would be very pleased to work with other trusts who are brought into the project.
Great, thank you. And there's a question from Alan who's asking, how do you intend on removing blocking from testing? Could we start a petition if there isn't one?
Okay. So I may not have been completely clear, Alan. Let me have another go. The intention is that everybody who goes into an emergency department and has a blood test is also given a blood-borne virus test. It's not a good use of resources to test people who've been tested in the very recent past through emergency departments. The test cost, give or take, let's say £10. It's different across different areas of the country according to their relationships and contracts with the labs that they use. So we don't want to test people on an each and every attendance basis, and we have recommended testing people every 12 months in emergency departments. Now, that's not to say that people should not test themselves elsewhere if they are very sexually active, but for the emergency department testing, 12 months is thought to be enough. Some trusts are using 6 months, some trusts are using 3 months. And by doing that, we reduce the number of tests, therefore we reduce the cost. But it doesn't have much impact on the individuals, because if they were to be tested elsewhere, you know, that would take care of anybody who has recently been sexually active. ED testing does not replace other forms of testing like internet, it adds to it. I hope that makes sense.
Yeah, that's very clear. Thank you very much. There's another question that's just come in. What impact does testing via mouth swabs, e.g. Quick, have on this, and what do you predict?
Alison, I don't know whether you would want to have some comment on this one.
The answer, I don't know the answer, I'm afraid. From what I understand, I think the accuracy is better from finger prick, but I think people find saliva tests more acceptable, particularly if they're self-sampling? I'm afraid I just don't know the answer to that question.
Yes, I mean, there was some conversation about for GPs whether an oral swab would be more acceptable than taking bloods, but I'm not very familiar with that conversation. And at the moment, within the ED setting, there is not the intent to use oral swabs, as far as I'm aware.
Okay, thank you. And there's a question from Daniela, who says the HIV action plan talks about increasing HIV testing done in sexual health services. They are very stretched at the moment. And do you know if there'll be any further funding made available for sexual health services?
As part of the HIV action plan, there was money committed to fulfil it. Lots of it has gone, understandably, to the ED testing, others to other areas such as health promotion, etc. I'm not sure what the cost allocation is, but what I do know is that we are evaluating the impact of it, and we do need to make sure that the government is held to account in terms of the money that has been promised as part of the action plan.
Thank you. Question from Dorothy, potentially a clarification, is have you seen success with the NHS trusts that are currently offering opt-out HIV testing, for example, King's College, London Hospitals, NHS Foundation Trust?
King's has done tremendously well, and they have been working, I think, since 2015 on ED HIV testing, and will shortly go live with hepatitis B, hepatitis C. So they have done tremendously well, but they've also proved the Princess Royal University Hospital is part of the King's Trust, and they have launched HIV testing, and again have done tremendously well. They've got a very high percentage of take-up, which is fantastic for an organisation that's only been doing it for less than 12 months.
Great. And then another question. So somebody who's done a lot of research around HIV, predominantly in sub-Saharan Africa, and recently relocated to the UK, is wondering if there's any way to link up with other researchers or research institutes that are undertaking research in HIV in the UK. Is anyone able to provide any assistance on that?
Well, we'll be happy to talk to anybody who is interested in the work we're doing, and we'll be very interested to hear the work that they're doing as well. I know there are some more formal ways of collaboration as well, such as being part of ECGC within Europe and other networks too. But if anyone was interested in working with us or talking with us and would like to share experiences, please do contact us. We'd be very happy to hear from you.
Great, thank you. And then, in the interest of time, we've got one question, so we'll just ask this one and then wrap up the webinar. So Catherine is asking, if somebody tests positive for HIV in emergency departments, how are those results then communicated to patient? Is it through a local sexual health clinic?
That's a really good question, Catherine, and my apologies for not having answered that within the presentation. So the emergency department clinicians, their only responsibility is to take the bloods. Any reactive tests are communicated through to the clinicians, and the sexual health clinicians are the ones that make contact and offer the chance to engage in care and treatment.
Okay, great, thank you. Well, somebody's popped one question in, so let's do this one, and then we'll wrap up. So I'm afraid we don't have time to do any more questions after this one. So someone just wants to know if STI testing is done concurrently with HIV testing, particularly among high-risk populations.
It depends where you test. If you're testing in a sexual health service, then yes, that you would have what's called a sexual health screen, which is the most common STIs as well as HIV. If you're doing community testing, etc., or ED testing, then ED testing is the 3 bloodborne viruses, but STIs would relate to sexual health services.
Okay, thank you very much, everyone for attending. I've popped a link to the SurveyMonkey in the chat, so if you do have time, please complete that survey. It's only 10 questions, so it'll take you about 5 minutes, and we'd really appreciate any feedback on the webinars that we host. And thank you very much to our speakers, Dr. Alison Brown and Steve Hindle. It was really interesting presentations. I know I've learned a lot and got some really good insights, so I hope everyone found that useful. The webinar will be available, the recording will be available to watch on YouTube if anyone sort of joined late or had to leave early. So thank you very much.